Chapter 30, Introduction to the Hematopoietic and Lymphatic Systems. Learning objectives. Define hematopoiesis. Name the major structures in the hematopoietic system. Name 3 types of blood cells produced by the bone marrow and discuss the function of each. List at least 5 components of plasma. Name 3 plasma proteins and explain the function of each. Identify the 4 blood groups and discuss the importance of transfusing compatible types. Explain the components and function of the lymphatic system and its role in hematopoiesis. Describe the pertinent assessments of the hematopoietic and lymphatic systems when obtaining a health history and conducting a physical examination. Name laboratory and diagnostic tests for disorders of the hematopoietic and lymphatic systems. Discuss the nursing management of clients with hematopoietic or lymphatic disorders. This chapter discusses the structures that are involved in hematopoiesis, the manufacture and development of blood cells. It also considers the lymphatic system, which includes the thymus gland and spleen, and this system assists in the maturation of certain lymphocytes, specific types of white blood cells. Anatomy and physiology. Hematopoietic system. Bone marrow. Bone marrow, the soft tissue that fills spaces in the interior of the long bones and spongy bones of the skeleton, manufacture blood cells. The 2 types of bone marrow are red marrow and yellow marrow. Red marrow is found in the ribs, sternum, skull, clavicles, vertebrae, proximal ends of long bones, and iliac crest. It manufactures blood cells and hemoglobin. Yellow marrow consists of fat cells and connective tissue. It does not participate in the manufacture of blood cells. However, yellow bone marrow can form blood cells under conditions involving intense stimulation, such as after significant blood loss or hemorrhage, and the lymphatic system also plays a role in hematopoiesis. Blood. Blood consists of cells suspended in a fluid called plasma. All blood cells are produced from undifferentiated precursors called pluripotential stem cells in the bone marrow. Myeloid stem cells are converted to erythrocytes, which are red blood cells, RBCs. Several types of leukocytes are white blood cells, WBCs, and platelets, also known as thrombocytes because they help control bleeding by forming a loose blood clot. Lymphoid stem cells are converted to lymphocytes. White blood cells with immune function and white blood cells with immune functions. Each component of blood has specialized functions. Erythrocytes. Erythrocytes, or red blood cells, are flexible, anuclear, which means lacking a nucleus, biconcave discs covered by a thin membrane through which oxygen and carbon dioxide pass freely. The flexibility of erythrocytes allows them to change shape as they travel through capillaries. Their major function is to transport oxygen and to remove CO2 from tissues. Production of erythrocytes is called erythropoiesis. The rate of erythrocyte production is regulated by erythropoietin, a hormone released by the kidneys. Erythrocytes arise from myeloid stem cells, which also require iron and B vitamins such as B12, B6, and folate to mature properly. Immature erythrocytes, known collectively as erythroblasts, go through several intermediary stages of maturation before being released into the blood. In their immature state, erythroblasts contain a nucleus. The mature erythrocyte has no nucleus. The normal number of erythrocytes varies with age, gender, and altitude, but ranges between 3.6 and 5.4 million per millimeter to the third. Infants have more erythrocytes than adults. Women have fewer erythrocytes than men. People who live at high altitudes or engage in strenuous activity have an increased number of erythrocytes to maximize the transport of oxygen and carbon dioxide. The red color of blood is the result of hemoglobin, an iron-containing pigment attached to erythrocytes. The heme portion of the molecule freely binds with blood gases. As erythrocytes pass through the alveolar capillary membranes, the hemoglobin picks up oxygen from the alveoli and releases carbon dioxide. The oxygen-saturated hemoglobin is called oxyhemoglobin. It circulates through arteries, arterioles, and capillaries to all body cells. After hemoglobin releases oxygen for use by the cells, the blood becomes dark red. The hemoglobin is then called reduced or deoxygenated hemoglobin, owing to the acquisition of carbon dioxide from cellular metabolism. In adults, the normal range of hemoglobin is 12.0 to 17.4 grams per dl. The amount of hemoglobin can vary according to the sex of the individual. Erythrocytes circulate in the blood for about 120 days, after which the spleen removes them. The liver removes severely damaged erythrocytes. When erythrocytes are destroyed, the iron component of hemoglobin is returned to the red marrow and reused. The residual pigment is stored in the liver as bilirubin and excreted in bile. Leukocytes, or WBCs, perform various functions that are protective, such as engulfing invading microorganisms and cellular debris and manufacturing antibodies. They not only circulate in the blood, but they also migrate from the blood into body tissues to search for and destroy potential harmful substances. The normal range of leukocytes is between 5,000 and 10,000 per millimeter to the third. An increased number of leukocytes is called leukocytosis. A decreased number is called leukopenia. So again, leukocytosis is an increased number and leukopenia is a decreased number. Chapter 30, page 505, figure 30-2 shows you the differentiated leukocyte counts. The lifespan of leukocytes is only 1 to 2 days. Consequently, the demand for the production of WBCs is continuous. The need is even greater with infection. Leukocytes are divided into two categories: granulocytes, which contain cytoplasmic granules, and agranulocytes that do not contain granules. Gerontological considerations. The components of blood change only slightly with age. The red blood cells become slightly less flexible and fewer in number. Lymphocytes also decrease in number, causing a decreased resistance to infection. Decreased renal perfusion can result in inadequate erythropoietin production, resulting in decreased red blood cell production. Granulocytes. Granulocytes, also called polymorphonuclear leukocytes, are divided into three subgroups: neutrophils, basophils, and eosinophils. Neutrophils are a major component of the inflammatory response and defense against bacterial infection, also called microphages. They protect the body by phagocytosis, the ingestion and digestion of bacteria and foreign substances. Immature neutrophils, called band cells, circulate in peripheral blood. Basophils are also capable of phagocytosis. They are active in allergic contact dermatitis, which is an immediate hypersensitivity, and some delayed hypersensitivity reactions. Eosinophils phagocytize foreign material. Their numbers increase in allergies, some dermatologic disorders, and parasitic infections. Agranulocytes. Agranulocytes are divided into two groups: lymphocytes and monocytes. Lymphocytes are divided into beta lymphocytes, or beta cells, which produce humoral immunity by producing antibodies called immunoglobulins, and T lymphocytes, or T cells, which provide cellular immunity or cell-mediated response. Beta lymphocytes produce antibodies against foreign antigens, and T lymphocytes interact with foreign cells and release a substance called lymphokine, which enhances the action of phagocytic cells. Some lymphoid stem cells mature in the bone marrow, whereas others migrate to peripheral lymphoid tissue to complete their maturation. So we went over bone marrow, and we're talking about blood cells right now, and specifically now we're talking about erythrocytes, which are red blood cells. Erythrocytes arise from myeloid stem cells, which also require iron and B vitamins such as B6 and B12 and folate to mature properly. And again, in review, blood consists of cells suspended in plasma. Pluripotential stem cells are the beginning. These produce all cells in the blood in the bone marrow. And the components of the blood plasma is erythrocytes, red blood cells, leukocytes, white blood cells, and platelets, thrombocytes, which form loose blood clots. Erythrocytes, or RBCs, are flexible, anuclear, lacking a nucleus, bioconcave discs covered by a thin membrane through which oxygen and carbon dioxide pass freely. The flexibility of erythrocytes allows them to change shape as they travel through capillaries. The major function is to transport oxygen and remove CO2 from cells, from the tissues. Production of erythrocytes is called erythropoiesis. The rate of erythrocyte production is regulated by erythropoietin, a hormone released by the kidneys. Erythrocytes arise from myeloid stem cells, which also require iron and B vitamins such as B12, B6, and folate to mature properly. Immature erythrocytes, known collectively as erythroblasts, go through several intermediary stages of maturation before being released into the blood. In their immature state, erythroblasts contain a nucleus. The mature erythrocyte has no nucleus. The normal number of erythrocytes varies with age, gender, and altitude, but ranges between 3.6 and 5.4 million per millimeter to the third. Infants have more erythrocytes than adults. Women have fewer erythrocytes than men. People who live at high altitudes or engage in strenuous activity have an increased number of erythrocytes to maximize the transport of oxygen and CO2. The red color of blood is the result of hemoglobin, an iron-containing pigment attached to erythrocytes. The heme portion of the molecule freely binds with blood gases. As erythrocytes pass through the alveolar capillary membranes, the hemoglobin picks up oxygen from the alveoli and releases carbon dioxide. The oxygen-saturated hemoglobin is called oxyhemoglobin. It circulates through arteries, arterioles, and capillaries to all body cells. After hemoglobin releases oxygen for use by the cells, the blood becomes dark red. The hemoglobin is then called reduced or deoxygenated hemoglobin owing to the acquisition of carbon dioxide from cellular metabolism. In adults, the normal range of hemoglobin is 12.0 to 17.4 grams per dl. The amount of hemoglobin can vary depending on the sex of the individual. Erythrocytes circulate in the blood for about 120 days, after which the spleen removes them. The liver removes severely damaged erythrocytes. When erythrocytes are destroyed, the iron component of hemoglobin is returned to the red marrow and reused. The residual pigment is stored in the liver as bilirubin and excreted in bile. Gerontologic considerations. The components of blood change only slightly with age. RBCs become slightly less flexible and fewer in number. Lymphocytes also decrease in number, causing a decreased resistance to infection. Decreased renal perfusion can result in inadequate erythropoietin production, resulting in decreased red blood cell production. Nutrients involved in red blood cell formation. Iron is the best building block of hemoglobin and the enzymes involved in red blood cell production. Iron is the basic nutritional component of heme and hemoglobin. Protein is the building block of hemoglobin and the enzymes involved in red blood cell production. Folic acid and vitamin B12 are essential for maturation of red blood cells. Vitamin C enhances the absorption of folic acid and iron. Vitamin B6 serves as a coenzyme in hemoglobin formation. Copper, even a minute amount, is involved in the transfer of iron from storage to plasma. Vitamin E protects blood cells from vitamin E deficient hemolytic anemia. Food sources rich in these nutrients are lean red meats for iron, such as lean meats, eggs, dairy, and legumes. Protein comes from animal products and supports B12. Dark leafy greens citrus, beans and lentils, seeds and nuts, folic acid, and citrus, which is vitamin C. And vitamin B12 comes from dark leafy greens, citrus, beans and lentils, seeds and nuts. Nuts actually is folic acid. Fortified cereals, beef and poultry provide B6. Shellfish, grains, beans, and nuts provide copper, and sunflower seeds, almonds, spinach, safflower oil, and asparagus provide vitamin E. Question. The nurse is educating the client regarding nutrition and the prevention of anemia and low hemoglobin. The nutrients involved with red blood cell formation include all of the following except. So A, vitamin C enhances the absorption of folic acid and iron. B, vitamin E protects blood cells from hemolytic anemia. C, vitamin B12 serves as a coenzyme in hemoglobin formation. And D, iron is the basic nutritional component of heme and hemoglobin. Your answer should be C, vitamin B12 serves as a coenzyme in hemoglobin formation. The rationale is folic acid and vitamin B12 are essential for the maturation of red blood cells, not hemoglobin formation. Hematopoietic system. Leukocytes. Leukocytes, or white blood cells, perform various protective functions such as engulfing invading microorganisms and cellular debris and manufacturing antibodies. They not only circulate in blood, but they also migrate from the blood into the tissues to search for and destroy potentially harmful substances. The normal range of leukocytes is between 5,000 and 10,000 per millimeter to the third. An increased number of leukocytes is called leukocytosis. A decreased number is called leukopenia. Table 32 on page 505 in your MedSurg TIMBY book shows the differential leukocyte count. The lifespan of leukocytes is only 1 to 2 days. Consequently, the demand for the production of white blood cells is continuous. The need is even greater with an infection. Leukocytes are divided into two categories. Leukocytes are divided into two categories. This is a picture of phagocytosis by an endothelial cell. The cell membrane of the neutrophil surrounds and pinches off the bacterium or dead tissue. Enzymes within the cell destroy the foreign material and pinch off, and you can see that it has enclosed the foreign material and will carry it away and dispose of it. Platelets, plasma and plasma proteins. Plasma is the liquid or serum portion of blood. It consists of 90% water and 10% proteins. Besides blood cells, plasma contains and supports proteins such as albumin, globulins, and fibrinogen. Clotting factors also are included, such as prothrombin, pigments, vitamins, glucose, lipids, electrolytes, minerals, enzymes, and hormones. Plasma is the liquid or serum portion of blood. It consists of 90% water and 10% protein. Besides blood cells, plasma contains and transports proteins such as albumin, globulins, and fibrinogen, and clotting factors such as prothrombin, pigments, vitamins, glucose, lipids, electrolytes, minerals, enzymes, and hormones. Albumin, which is formed in the liver, is the most abundant protein in plasma. Under normal conditions, albumin cannot pass through a capillary wall. Consequently, albumin helps maintain the osmotic pressure that retains fluid in the vascular compartment. Globulins are divided into three groups: alpha, beta, and gamma. The gamma globulins are also called immunoglobulins. Globulins function primarily as immunologic agents. They prevent or modify some types of infectious diseases. Like albumin, they help maintain osmotic pressure in the vascular compartment. Talking about albumin. Fibrinogen plays a key role in forming blood clots. It can be transferred from a liquid to fibrin, a solid that controls bleeding. Blood groups. There are 4 groups or types, A, B, AB, and O, which are determined by heredity. Blood type is ascertained by identifying the protein or antigen on the red cell membranes. Group A has A antigen, Group B has B antigen, Group AB has A and B antigen, and Group O has no antigen. Antibodies, immunoglobulins, and plasma that inactivate any substance that is non-self react with incompatible red blood cell antigens. Therefore, people with type O blood are termed universal donors because they do not have antigens on the red cell membrane. Clients with all blood types can receive type O blood provided the Rh factor is compatible. Those with type O blood, however, can only receive type O blood. People with type AB blood are considered universal to recipients because both A and B antigens are present on the red cell membrane. Clients with type AB blood can receive blood from persons with any type of blood, but the Rh factor must be compatible. The Rh factor is a specific protein on the red blood cell membrane. If the protein is present, the Rh is negative. If the protein is present, the Rh person is Rh positive. If the protein is absent, the person is Rh negative. When blood is transfused, donor blood must be both type and Rh compatible with the recipient's blood. The donor's blood is typed and labeled at the time of donation. When a blood transfusion is needed, the recipient's blood type is typed and cross-matched, matched for compatibility with donor blood. Donor and recipient blood are considered compatible if there is no clumping or hemolysis, which is destruction of erythrocytes, when both samples are mixed in the lab. In an emergency, type O blood can be given to recipients with type A, B, AB, or O. People with Rh positive blood can receive Rh positive or Rh negative blood because Rh negative indicates the Rh factor is missing. Those with Rh negative blood, however, must never receive Rh positive blood regardless of whether the blood type is compatible. A client involved in a motor vehicle accident requires a blood transfusion due to excessive bleeding injuries. The client is typed and cross-matched for the blood transfusion and is tested as having type AB blood. What blood type would be compatible for this client? Type A, type B, type O, or type A, Rh positive blood? The answer is type O blood. In an emergency, type O blood can be given to recipients with type A, B, AB, or O. Lymphatic system. The lymphatic system includes the thymus gland, spleen, and a network of lymphatic vessels, lymph nodes, and lymph. This system of lymphatics circulates interstitial fluid and carries it to the veins. Along the pathway, the lymphatic system filters and destroys pathogens and removes other potentially harmful substances. Cellular and humoral immunity are affected by age-related changes in the lymphatic system, including decreases in primary antibody, T cell and B cell responses, and antibody production. This results in an increased susceptibility of older adults to infections and malignancies and an indication for recommended adult immunizations. Thymus gland. The thymus gland is lymphoid tissue in the upper chest that contains undifferentiated stem cells released from bone marrow. Once the undifferentiated cells migrate to the thymus gland, they develop into T lymphocytes, so called because they are thymus-derived. Spleen is the largest lymphatic structure. It lies in the abdomen, beneath the diaphragm, and behind the stomach. The spleen is a reservoir of blood and contains phagocytes that engulf damaged erythrocytes and foreign substances. Lymph nodes. Lymph nodes are glandular tissue along the lymphatic network, are clustered in the axilla, groin, neck, and large vessels of the thorax and abdomen. Lymphatic ducts through which lymph flows connect the nodes. The nodes contain both T and B lymphocytes released from the bone marrow but do not reach the thymus gland in the smaller nodules of each lymph node. Lymph. Lymph is fluid filled with a composition similar to plasma. It flows through the lymphatic system by a contraction of skeletal muscles. Lymph enters each node by way of the afferent lymph duct, passes through the node, and leaves by the efferent lymph duct. As lymph passes through the node, macrophages attack and engulf foreign substances such as bacteria and viruses, abnormal body cells, and other debris. Spleen. Both hematopoietic and immune functions are carried out in the spleen. It also holds an emergency reservoir of blood and removes bacteria and old or damaged red blood cells from circulation. The thymus gland produces lymphocytes during fetal development. After birth, thymus gland programs T lymphocytes to become regulator or effector T cells and become smaller during adolescence. Tonsils include the palatine, pharyngeal, and lingual tonsil. Health history assessment. The health history includes the client's description of signs and symptoms. If abnormalities are present, the nurse determines when the signs or symptoms began, their severity, and their frequency. In relation to the hematopoietic and lymphatic systems, it's important to establish if the client experiences prolonged bleeding from an obvious injury, has unexplained blood loss, as in rectal bleeding, nosebleeds, bleeding gums, or vomiting blood, feels fatigued with normal activities, becomes dizzy or faints, bruises easily, is easily chilled, has frequent infections, feels discomfort in the axilla, groin, or neck, has difficulty swallowing with localized throat tenderness, has had surgery with lymph node removal or splenectomy, is undergoing treatment for cancer, or has renal failure, all of which affect blood cell volume or lymphatic circulation. The nurse obtains a dietary history because compromised nutrition interferes with the production of blood cells and hemoglobin. The nurse takes a drug history of prescription and non-prescription medicines. Some antibiotics and cancer drugs contribute to hematopoietic dysfunction. Aspirin and anticoagulants can contribute to bleeding and interfere with clot formation. Because industrial materials, environmental toxins, and household products can also affect blood-forming organs, the nurse explores any exposure to these agents. The nurse also asks about foreign travel to countries where malaria or parasitic roundworms are common. The agent that causes malaria following the bite of an infected mosquito invades erythrocytes and causes anemia. Filariasis, also known as elephantiasis, is a consequence of a roundworm infection in which the lymphatic vessels become occluded. Many pharmacologic agents affect the hematopoietic system, causing a decrease in venous blood components. Closely monitor clients taking medications that depress the hematopoietic system, particularly thrombocytes and leukocytes, for signs of leukopenia, which is fever, sore throat, and chills, and thrombocytopenia, which is unusual or easy bleeding, oozing from injection sites, bleeding gums, and dark tarry stools. Physical examination. Physical examination includes inspection of the skin with particular attention to color, normal, extreme redness, or pallor, temperature and ecchymosis or other lesions, A rapid pulse rate can indicate reduced erythrocytes or inadequate hemoglobin levels. The nurse palpates the lymph nodes in the neck for tenderness or swelling and notes the size, location, and characteristics of symptomatic lymph nodes. He or she examines the skin adjacent to the nodes for redness, streaking, or swelling. Using a penlight and tongue blade, the nurse inspects the tonsils for size and appearance. If the tonsils are present, the nurse uses the following scale to document assessment findings related to size. 1 to 4. 1 is tonsils are visible. 2, tonsils extend medially toward the uvula. 3, tonsils touch the uvula. And 4, tonsils touch each other. Purulent exudate on the surface of the tonsil suggests tonsillitis. The nurse examines the extremities to determine if they are similar size. Obstruction of lymphatic circulation can cause unilateral enlargement. Diagnostic tests. The nurse obtains a blood sample from a vein, finger, or earlobe. The blood sample is used to perform a complete blood count or to measure the hemoglobin. The physician may order other blood tests that reflect the client's clotting status, such as prothrombin time, fibrinogen level, activated partial thromboplastin time, D-dimer test for fibrin, and fibrin degradation products, and factor assays. A bone marrow aspiration is performed to determine the status of blood formation. In this procedure, the physician applies local anesthesia and removes bone marrow from the posterior iliac crest or the sternum. The marrow is examined for the types and percentage of immature and maturing blood cells. The nurse assists the physician, supports the client during the procedure, and monitors the client's status afterward. A Schilling Test is used to determine the etiology of vitamin B12, cobalamin deficiency, causing pernicious anemia. The test is performed in 4 separate stages. In each stage, oral, radio-labeled vitamin B12 is administered. Radio-labeled means the substance has been tagged with radioactive tracer. In the first and subsequent stages, the oral, radio-labeled vitamin B12 is combined with an intramuscular injection of non-radio-labeled vitamin B12. Then oral intrinsic factor, which is secreted by parietal cells in the stomach to aid absorption of the vitamin. Next, an antibiotic like tetracycline for 2 weeks, and finally protease, a pancreatic enzyme that frees B12 to bind to the intrinsic factor. After each stage is completed, a 24-hour urine specimen is collected. Depending on whether the radio-labeled vitamin is low or high in the urine, the etiology may be one of the following. Dietary deficiency of vitamin B12 often occurs among vegans who did not consume animal proteins, a source of the vitamin. Deficiency of the intrinsic factor that may be due to having had a gastrectomy or a gastric bypass. Malabsorption of B12 due to intestinal bacterial overgrowth or disorder affecting the terminal ileum like Crohn's disease, where a major portion of B12 is absorbed, or deficiency of protease, common among those who have pancreatitis, and that interferes with the binding of free B12 to the intrinsic factor. Once the etiology is determined, the treatment of the anemia is based on its cause. The Schilling test may pose a problem in older adults if proper collection of the 24-hour urine specimen is not possible as a result of cognitive problems or urinary incontinence. Recent research indicates that gastric pH levels vary in older adults, requiring individual consideration of appropriateness of the Schilling test to detect B12 deficiencies for older adults. However, the full Schilling test is indicated if other causes are suspected. Lymphatic disorders are diagnosed using procedures such as lymph node biopsy, ultrasound of the spleen or selected lymph nodes, and lymphangiography, which is radiographic examination using contrast media. Additional diagnostic tests include radiography, computed tomography, bone scan, and MRIs. Although they are not specific for hematologic or lymphatic disorders, they are used to rule out other disorders or note changes in organs that have a direct or indirect relationship to a hematologic or lymphatic disorder. Question. The nurse needs to monitor clients taking medications that can contribute to hematopoietic dysfunction. Medications that interfere with the hematopoietic system include A. Neupogen, B. Coumadin or warfarin, C. Epigen, or D. Neulasta. The answer is B. Warfarin, otherwise known as Coumadin. Warfarin/Coumadin and aspirin and other anticoagulants can contribute to bleeding and interfere with clot formation. Nursing management. The nurse collects appropriate data to assist the physician in diagnosing hematologic or lymphatic disorders and the client's response to treatment. Before any diagnostic testing, the nurse determines the client's knowledge of the procedure and offers a description of the test routine, what tasks are necessary to participate in the test, and any potential for discomfort. The nurse wears gloves when collecting specimens. After collection, he or she checks the specimen for a correct label and immediately takes it to the laboratory. When the test involves a puncture, the nurse assesses the area for excessive bleeding and applies pressure or pressure dressing to the site as needed. The nurse monitors vital signs to assess the client's recovery, notifies the physician regarding adverse responses, and analyzes and reports test results promptly. This is the end of the slideshow.